Okay, hello and welcome to the Low Risk Birth Quality-Based Procedure webinar by the Provincial Council for Maternal and Child Health, later on referred to as PCMCH. And this is a joint with the Ministry of Health and Long-Term Care. My name is Laura Zardine, Program Coordinator at PCMCH, and will be helping and facilitating the webinar today. The webinar will be presented by Dr. Georgina Wilcox. She's an obstetrician and gynecologist at the Scarborough Hospital and an assistant professor of the Faculty of Medicine at the University of Toronto, as well as a member of our QVP expert panel. I will be handing it off to Danielle from HTO to provide some tech support for how the webinar will function today.
Hi, great. Good afternoon, everyone. The first thing that we'll test is we'll just do a sound check. And so someone can let us know in the chat box if you're able to hear us okay. And I will wait for the team here to give me a thumbs up. We have seen lots of thumbs up. That is great. Thanks so much. So for today's webinar, a couple of things. If you are having any difficulty with your sound, we do recommend we switch to telephone. Sometimes when people encounter sound difficulties, it has to do with internet connection over their computer. If you are having any difficulties beyond that, again, feel free to note that in the chat feature, and a member of the team here will try to help. So handouts for today's webinar have been posted in the GoToWebinar panel. There's a screen capture of that here, so you should be able to see in one of the lower parts of the panel a section for handouts. And we will be recording today's webinar, and all attendees will get a copy of that after. And as I mentioned, we will be taking questions at the end of today's webinar. Feel free to jot down your questions throughout. There's a team here that will be answering them as they go. They'll also be compiling them. We have quite a few people on today's webinar, so it is possible that we won't get through all of the questions at the end, but if there are any unanswered questions, rest assured that we'll follow up with everyone and with the group to let them know the answers to that. So feel free to send those in throughout. And with that in mind, I think I will turn it back to our colleagues from PCMCH to get started.
Great. Thank you so much. So just a brief agenda. So our introduction will focus on what is a quality-based procedure and its importance. We'll provide some context as to why we are promoting low-risk birth. We'll present the clinical recommendations from the quality-based procedures, the implementation consideration, tools regarding the low-risk birth QVP, and at the end, we'll have time for discussion. Okay, so I'll just go over the QVP for low-risk birth and a little bit of an introduction of what that is. So the purpose of this presentation is to review the clinical recommendations of the low-risk birth quality-based procedure, which you can find online at the Ministry of Health and Long-Term Care website or at www.pcmch.on.ca. So what is a QVP? QVPs are an integral part of Ontario's health system funding reform, otherwise known as HSFR. A key component of patient-based funding and plays a key role in advancing the Government of Ontario's quality agenda and its action plan for healthcare. HSFR allocates funds based on price, volume, and quality approach, premised on evidence-based practices and available data. It has been identified as an important mechanism to strengthen the link between the delivery of high-quality care and fiscal sustainability. So why is this important? This QVP was developed as part of Ontario's health system funding reform to promote normal birth, address the variation in C-section rates across the province in the low-risk mother, improve patient outcomes via focusing on the delivery of standardized evidence-informed practices. Hospital funding changes with regards to how low-risk birth will be remunerated are planned for the 2019-2020 fiscal year. This year, 2018 to 2019, will be a year for clinical adoption. This webinar will provide a high-level overview, but for more information, refer to the Low-Risk Birth QVP Toolkit and the QVP Handbook for Low-Risk Birth. Born Ontario will be developing a data report to support the implementation of the clinical recommendations. PCMCH will be hosting a series of webinars, including one focused on funding and related questions in the near future, hopefully winter 2018-2019. For more information and resources, please check out our website at www.pcmch.on.ca. And now I'll hand it off to Dr. Georgina Wilcox to start us off on some of the context.
Okay, and just a correction, my academic appointment is to the Department of OB/GYN, not to the Department of Medicine. And I'll start with a poll. why are we concerned about a rise in C-section rates? And this is now for everyone to answer. Right?
We're just going to give people a couple of seconds to respond to the poll. The team here will let us know when we're near 80%, and then we'll be able to show the results.
Okay, so the polling question is, why are we concerned about a rise in C-section rates? Your options are a lack of parallel decreases in infant mortality and morbidity, risk of immediate and long-term maternal complications, risk of immediate and long-term neonatal complications, rising healthcare costs, and all of the above. So, are we ready to release the results? Okay, so we have 97% stating all of the above. That is the correct answer. Thank you very much.
Good. Thank you. And to go on and put this in some context, in terms of background, this slide is showing the rate of cesarean section, all cesarean sections, in Ontario in the last 10 years, well, from 2006 to 2016-17. And it should be noted that we haven't seen really a change in our cesarean section rates since 2006, and they still range between 27 to 28 throughout Ontario. This is all cesarean sections, but the QBP will actually be concentrating on a specific subgroup of cesarean sections. And in order to do that, I need to digress and just for everyone explain the Robson criteria. Robson classified women having cesarean section into different groups so as to be able to look at a more homogenized group when looking at cesarean sections. And he divided women having cesarean sections into 10 different groups. The group we are going to concentrate on is Robson Group 1. And Robson Group 1 is essentially healthy women with no other risk factors, with a singleton fetus, cephalic presentation, more than 37 weeks gestation, and in spontaneous labor. And the expert panel agreed that to further look at this group, we would also take out women over the age of 35 and women with a BMI of greater than 40. And when looking at this group, we need to look at, and one of the concerns is if you look at the whole of Ontario, 85 different hospitals, the range at which Robson Group 1 women are getting C-sections is as low as 5% in one hospital, right up to 38% in another hospital. And in fact, almost 30% of these hospitals have an over 15%, and about 10 or so of the hospitals have an over 20% cesarean section in their Robson Group 1. And this was a concern. Why is there such variation in the cesarean section rates?
Great. And that takes us to our next polling question. So the next polling question is, which one of the below is the highest reported primary indication for cesarean section? Your options are atypical or abnormal fetal surveillance, repeat cesarean section, malposition, non-progressive first stage, or non-progressive second stage. We'll give you guys a few moments to lock in your votes. Okay, he is 80% now. So I'll just go through the answers. So we have 36% state that it's a repeat cesarean section, 22% say atypical or abnormal fetal surveillance, 30% say non-progressive first stage, 11% non-progressive second stage, and 1% malposition. So the next slide shows you what the answer is. So 35.2% is the highest indication, primary indication for C-section is repeat cesarean section, which majority of people voted for, so that is correct. The second highest was non-progressive first stage, where that actually is the atypical or abnormal fetal surveillance at 14.9%. The third most prevalent is malposition, and malposition was voted as 1%. So if you do want to see a full list of the primary indications for C-section, it is available on Appendix A of the QBP handbook.
Okay, and why are we concerned about cesarean section? To put it in context, cesarean sections can be and are life-saving for both the baby and the mother at different times, or both. And I think it's important to always understand that birth itself is dangerous. The overall severe morbidity from a vaginal birth is quoted as 8.6%, but that for cesarean section is higher at 9.2%. Maternal mortality is 3.6 per 100,000, but when we look at cesarean births, it's 13.3 per 100,000. Amniotic fluid embolism is rare, but it's 5 times higher in cesarean birth. Third and fourth degree tears, of course, don't occur with cesarean section, but if you look at urinary incontinence, and this is from the term breach trial, there was no difference in urinary incontinence at 2 years between cesarean section and vaginal birth. There's also long-term risks of cesarean section, and the thing that is more and more worrying is abnormal placentation and the very serious morbidity associated with this, and repeat cesarean sections increasing the rate at which there's abnormal placentation. Cesarean sections are surgery. They can lead to adhesions, which can lead to bowel obstruction, and there is always, in patients with a scar in their uterus, an increased risk of uterine rupture. There's also some neonatal risks, which are suggested, including increased NICU admission, difficulty with breastfeeding, and there is evidence suggesting that babies born by cesarean section have an increased incidence of asthma. And for those reasons, the ministry, and concern about safety, was to look at not only cesarean sections and what is a safe cesarean section rate, but we've talked again about the range or the distribution at which cesarean sections are being done, and this is again for the QBP target population, low risk, in this slide. And this slide is looking at the whole of Ontario, but broken down by limb. And the bars you can see there is the blue bar is level 1 hospital, the green bar is level 2 hospitals, the yellow bar is level 3 hospitals, and the total is summarized in the gray bars. And if you look at this, you can almost see that there's a postal code difference. I think your lowest chance as a low-risk woman with her first baby of having a cesarean section is in the southwest limb in a level 2 hospital. But your highest chance is in my limb, the central east limb, in a level 1 hospital. And that's quite a range from about 8% to 24% chance of a cesarean section. Generally, if you look throughout Ontario, level 3 hospitals have the lowest rate of cesarean section on low-risk women. Level 2 are pretty comparable. There is concern about the level 1 hospitals and the much higher rates of cesarean section. And I'm hoping there will be people on this webinar from the level 1 hospitals who will comment and question. So the goal of the low-risk birth QBP is to reduce the variation in cesarean section in low-risk women via the adoption of evidence-based guidelines that promote vaginal birth. And any reduction in primary cesarean section will also positively impact on the rate of repeat cesarean section. And we saw that's the #1 reason for cesarean sections in Ontario. The scope of recommended interventions that may impact the risk of cesarean section include pre-pregnancy phase to post-delivery management, as well as retrospection and evaluation. The inclusion criteria, and I spoke about this before about the Robson criteria, the expert panel wanted to focus on as homogeneous group as possible, for whom the evidence supports specific interventions that are likely to promote vaginal birth. The patient cohort defined by this QBP was comprised of women with the following characteristics. They all belong to Robson group 1, and I will repeat, that is nulliparous, with a singleton gestation, cephalic presentation. They're in labor after 37 weeks of gestation, so term, and it is a spontaneous labor. The expert panel added under 36 years of age at the time of delivery and a pre-pregnancy BMI of less than 40. And again, to emphasize, with no medical complications of pregnancy. And here's just some of the exclusion criteria, they're listed there, and I'm not going to go through them all, but note that even gestational diabetes puts you in an exclusion criteria, as do hypertensive disorders in pregnancy. And all of this information can be captured in the BORN database. So the QBP came up with recommendations based on evidence-informed practices in order to follow through with recommendations for the patient, both from pre-pregnancy, antenatal, term, management of labor, and post-delivery, as well as retrospection and evaluation. And the scope of the recommended interventions that may impact the risk of cesarean section are present at all these phases. And therefore, we came up with these recommendations, which are in the handbook, but which I will discuss now. So the first thing is pre-pregnancy, to increase knowledge and awareness about a healthy pregnancy through the healthcare provider and through information which is available to patients. And there's some excellent programs such as the Mothers Program, which is an online educational tool which is accessible without any sign-ins. Oh Mama has been produced actually by BORN, and again has much information and has apps which can be downloaded. The Association of Ontario Midwives again has very valuable educational tools, as does the Society of Obstetricians and Gynecologists. Health Canada has also come up with a sensible guide to healthy pregnancy. So there's much information, and patients who are considering a pregnancy should be directed to go to one of these reputable, good sites with excellent information available. So once the patient's pregnant, we now get into the antenatal phase and the recommendations for the patient. Firstly, it's important to inform women that appropriate weight gain and regular exercise appears to decrease their risk of cesarean section. And when we're talking about normal weight gain for a normal weight patient coming into the pregnancy, the recommendation is 11 to 16 kilograms. If the patient is overweight at the time of the commencement of her pregnancy, she should probably only gain between 7 and 11.5 kilograms. And if she's obese, she should gain less than 7 kilograms. It is important to recommend routine early dating ultrasound so that we have the best estimate of the expected date of delivery. And this is important in terms of later on in the pregnancy and deciding when or not she's going post-date. Counsel women during the antenatal phase about practices that support vaginal birth. And these include discussing healthy weight gain, discussion about the latent phase of labor, and the fact that admission to hospital early in the latent phase of labor is associated with higher rates of cesarean section. If the patient has these discussions with her antenatal caregiver, she's more likely to trust the labor and delivery when they say, oh, you're only in the latent phase, you need to go home. But if this is the first time she hears it, she's not going to be so willing to try to manage that stage of her labor at home. Pain management strategies can be discussed, and again, pain management in the latent phase, so as to support patients staying at home longer. The benefits of continuous labor support. Every study looking at what helps for preventing cesarean section, when they look at continuous labor support, it always is shown to decrease the rate of cesarean section. And patients should be encouraged to be informed about this and given access to resources about not only support from family and training family members, but also support, doula support. The importance of positioning should also be discussed as to the benefits of intermittent auscultation. Patients may be unsure about what's going to happen in labor and delivery, and they may just be expecting that they would be strapped to a monitor. Yet the evidence is that patients with intermittent auscultation, it is safe, it is effective, and it does not increase the cesarean section rate. And low-risk patients should be informed that there may well just be intermittent auscultation of the fetal heart to monitor fetal well-being during the labor. From 37 to 41 weeks, the recommendations are, and just to let you know, the QVP and the expert panel, we did not get into discussing induction of labor and post-dates labor and induction, and specifically I'm saying this in the event of the ARRIVE trial. The ARRIVE trial has still not been published. There was a presentation at the Society of Fetal Medicine, but it was just a presentation. Currently, SOGC and the American College of Obstetricians still recommend that inductions are only started for no other reason, for post-dates at 41 weeks. Of course, if there's a medical indication, they would be done earlier, but to this point, the recommendations are still that an induction of labor for post-dates is only after 41 weeks, unless there's a medical indication. Utilize safety tools to ensure proper indication of induction of labor. And if a patient chooses to go on in labor after between 41 to 42 weeks, they should be informed of the increased risk of having a cesarean section, and they should have much closer monitoring with twice-weekly assessments of fetal well-being. The expert panel did suggest offering or recommending membrane sweeping or cervical massage to promote the onset of labor and avoid the likelihood of induction. Membrane sweeping has been demonstrated that you need to do 8 membrane sweeps to avoid 1 induction. So that's a pretty high rate of treatment to response. And but it should also be discussed with the patient and her consent obtained, because this is a painful procedure and often gives her irritating cramping and bleeding. From 37 to 40 weeks, we're still continuing on that. If they offer external cephalic version in cases of breech presentation before term when appropriate. Fetal presentation should be documented at 36 weeks, and patients offered ECV for breech presentation at 37 weeks. Regional analgesia may enhance ECV, and we did even at the expert panel discuss the fact that giving a spinal through an ECV could be an option even in a patient who's booked electively for a C-section, if she wanted one last try at the time of her delivery to attempt an ECV. But of course, if you did that, you're going to be in trouble with your OR and your anesthesiologist. But we need to continue mentorship and training in ECV from both obstetricians, family doctors, and midwifery providers, so that this service can be provided, as it will help to prevent that 10% of malpositions, most of which were breaches, which are undergo cesarean section. We need to establish standard protocols for induction of labor, which include indications for induction and adequate cervical ripening for labor induction. So we now move on to the management of labor. So before I go into the slide, I need to digress and talk just a little bit about Friedman Curves, which any obstetrician here knows has been the rule book of the management of labor and delivery units for eons. And the interesting thing with Friedman is he established his curves based on study of 500 women, and this was in the 50s. Most of the women who had babies in the 50s were in their 20s and probably had lower BMIs than currently. And when Friedman suggested his curves were that the dilatation would be 1 centimeter an hour in primates and 1.5 centimeters an hour in multiples. In 2011, Zhang did a retrospective study in 19 US hospitals looking at 62,000 deliveries, women who delivered and went back and looked at their labors. And he actually came out with the findings that labor is probably a lot slower than Friedman's curves have allowed us, and that labor is slow, and that latent phase is long, and from Zhang's study, primates, some of them were only dilating at about 0.3 to 0.5 centimeters an hour. Zhang also pointed out that latent phase is long and can often be 20 hours. Latent phase, the best, safest place for latent phase is home, and we need to delay admitting patients in the latent phase of labor and inform them of the risks of admission prior to active labor. Where possible, electronic fetal monitoring should be avoided, and monitoring should be with intermittent auscultation. We need to provide the patients with as much information on pain management or alternatives. And again, emphasize, provide one-on-one support during active labor. Perform assessment of fetal well-being using evidence-based methods, and again, intermittent auscultation is preferred as it has a lower intervention rate than the electronic fetal monitoring. And even with an epidural in place, it is safe to use intermittent auscultation to monitor. Perform assessment of fetal well-being in the presence of abnormal or atypical fetal heart rate tracing. And here I'm actually going to refer you to an excellent document produced by ACOG, which is avoiding the first Cesarean section, where they have an excellent discussion about the management of abnormal fetal heart tracings. And we talk about normal, atypical, abnormal, or type 1, type 2, and type 3. And in that document, they actually postulate that many of the Cesarean sections we do with concern about fetal heart rate tracings are actually done for probably type 2 or atypical. So with those atypical heart rate tracings, what can we do? We don't want to miss an abnormal, and we need to react fast to an abnormal, and at that point a Cesarean section can be life-saving. But to differentiate what is abnormal or atypical. Scalp stimulation has been shown to provide indirect assessment of acid-base status, and for those who are not aware, it's just when examining the fetus, the scratching of the scalp and seeing a tachycardic response from the fetus suggests fetal well-being. Fetal scalp sampling at gestations greater than 34 weeks gives an at that time assessment of acid-base status of the fetus. It has never gained much favor, I think partly because it's invasive. It involves a laceration of the fetal scalp. It's collecting blood. It gives you only real-time what's happening at that point, and has never really been used in Ontario in any great extent, but again, maybe someone can comment from some of our listeners. Amnio infusion, the ACOG document recommends this and states that there is level 1A evidence to support use of amnio infusion for management of variable deceleration, and that it may safely reduce rates of cesarean section. Pretty easy to do, although we did notice at the expert panel that it is not done in many hospitals in Ontario. But given that ACOG recommends this and states 1A evidence in support of using amnio infusion, we need to look more closely at adopting this as a possible way of avoiding unnecessary C-section. Further management of abnormal first and second stage. Definitely in the latent phase, early labor, encourage an upright position of women. Do not do cesarean sections for a latent phase. The American College of Obstetricians and Gynecologists is now calling active labor only at 6 centimeters dilated, but the SOGC still says 4 centimeters dilated, and for that reason the expert panel went with 4 centimeters dilated. We are again saying labor may be slower than we gave it credit for. Augmentation with oxytocin for up to 8 hours in the first stage of labor. And waiting for up to 2 hours prior to the onset of pushing is safe. In terms of the amount of time to push, we're kind of now pushing it to 3 hours with an epidural, 2 hours without. But in fact, there's no maximum time to the second stage of labor has been identified. And in terms of assisted vaginal delivery, it is not recommended at less than 2 hours, as long as there's no fetal reasons. If there's fetal reasons, do it straight away, after the commencement of pushing. And we need to support the training of skills related to assisted vaginal delivery, and to realize that in big studies, comparisons of outcomes of assisted vaginal deliveries and unplanned cesarean sections do not show any difference in serious neonatal morbidity. And a more recent study in 2011, forceps-assisted vaginal deliveries were associated with a reduced risk of serious neonatal morbidity as compared with cesarean section and vacuum. But there was no significant difference between unplanned cesarean sections and vacuums. So we must not lose this important skill of assisted vaginal deliveries. In the setting of fetal malposition, that's most likely transverse or posterior position of the fetal head. Consider manual rotation of the fetal occiput, which, if you've done it a few times, it's actually relatively easy and can quite quickly effect a normal vaginal delivery with no instrumentation. In terms of post-delivery management, use of evidence-based approaches for post-delivery management to promote optimal outcomes and reduced length of hospital stay. Newborns need to be skin-to-skin for at least 1 hour. Multimodal co-analgesia should be used to manage pain and encourage early ambulation. Surgical site prevention, infection prevention, and VTE prophylaxis. If a patient does have a cesarean section, discuss the options of vaginal birth and subsequent pregnancy. And then we get to the retrospective evaluation and review and recommendations. And it has been shown that where you just have collection of data and feedback in terms of cesarean section, you can reduce your cesarean section rate by about 13%. If you then move to culture change, where you would have such things as consultation request before doing a cesarean section, you can move your cesarean section rate even lower. Each hospital, in order to do this, needs to establish an interdisciplinary committee to monitor and review performance metrics. We need to review the number of post-dates inductions before 41 weeks and whether it was medically indicated. Hospitals should review C-section rates by healthcare provider. and identify opportunities for improvement. C-section and all QBP metrics should be shared publicly to promote quality improvement. LINs should monitor hospital performance. PCMCH, via the LINs or local regional maternal child networks, may act as a support to hospitals in enlisting mentorship support. In terms of implementation, it's necessary always with these new innovation is to identify site champions to integrate recommendations in hospital policies and procedures, convene and implementation a team that may include administrative leads, physicians, midwives, clinical practice leads, nursing, decision support, executive sponsors, communication strategists, and patient representatives. Conduct current stage gap analysis and review quality indicators. So in terms of implementation, review again the pathway, integrate it into the institutional practices, identify areas for improvement, and there must be some people from some of those hospitals that had a 5% cesarean section rate who are here now, and maybe they can add to the debate and we can all learn from them. And you can pat yourselves on the back. Develop operational strategy, review progress through reporting, audit and feedback, engage and promote experience with others. And that's where the different hospitals are talking to one another. And having said that, I'm not saying a 5% is the safest, but we need to look at our cesarean section rate. So BORN, the Better Outcomes Registry and Network in Ontario, is developing a data report to support the implementation of clinical best practices with respect to low-risk births. This report will be an important resource to monitor implementation and progress across the province. And report development has been initiated and work will be ongoing in 2018 to 19. So the tools we currently have are the user guide toolkit, the educational slides, the teaching notes, and coming soon will be patient education material and the BORN data report. So now I hand it over to you for discussion and questions.
Yeah, so we'll now begin the Q&A session. So if you do have any questions, just feel free to submit them. And then we'll see if we can answer them verbally with our expert, Dr. Georgina Wolkoff here.
Or other people in the audience.
Yeah.
And we can also put those questions out to other people. I'm sure these people are far more expert than myself, sitting in and listening. So, yeah. If anybody also wants to answer those questions, just put up your electronic hand.
Okay, so there is one question from Andrea Cassidy. Was consideration made to include the research about place of birth that is out of hospital versus hospital birth and the impact on C-section rates and the type of provider in C-section rates during the low-risk QBP?
That's an interesting question. I don't remember, and we did have midwives on QBP. Maybe some of them are on this webinar now, but I don't remember that coming up as something to look at.
Yeah, the QBC is hospital specific.
And I think it was really because the ministry was looking at, it's also about funding, isn't it? And funding through hospitals. So it's the way the hospitals are funded, so wouldn't really be looking at home births. But it's still an interesting question.
Yeah, and I think the clinical recommendations can still apply whether you're at home or whether you're in a birthing facility or in a hospital. So they're still relevant.
Mm-hmm.
So we have a question from, okay, so we have a question. What is the risk of rupture of membrane with membrane sweeping procedure?
It's about 1 in 10. And I actually think if you're doing informed consent, the patient should be informed that there is about a 1 in 10 chance that her membrane could rupture.
Great. All right.
So there is a question regarding the clinical handbook. It's not currently funded as a QBP. Is the intent to fund it as a QBP in the future? So we won't be discussing the funding for the QBP in detail at this webinar, but it is intended to be funded next fiscal year. So that's fiscal year 2019-20.
And when we have more information about that, hopefully we'll host another webinar or provide that information in some other way.
At a later date.
We have a question about, is there a way for consumers, non-regulated healthcare professionals, to be involved in this process?
So the consumers being patients having a baby, right? And so I always think that it's important for the receivers of healthcare to be involved in any process which involves their healthcare. So I would say it's about informed consent. They should know about these recommendations. They should know about best practice. But were you specifically thinking about feedback from the consumers of the healthcare, or?
I was wondering if they were wondering about were any patients or public involved in the quality or the QBP consultation. But maybe we will have to follow up with that.
Yeah, I mean, if it's in regards to like patient education material, to have them be aware of what the QBP is about, we do have that coming in the near future, hopefully, where we can create some patient education material.
The appendix has the list of the people on the QBPs, and I don't remember there being a consumer as one of the. It's in the appendix, the actual list of everybody who was on the expert panel for the QBP.
So the next question asks, although fetal scalp sampling is difficult, what about fetal lactate sampling is relatively easier?
Yeah, it is relatively easier, and you need less blood, and it's quicker to do, and it gives you a good, again, assessment of fetal well-being and fetal oxygenation. So possibly it will be, there'll be more uptake for it. I personally think that anything you can get to monitor fetal well-being and possibly avoid a cesarean section, if you get a reassuring level of the lactate, you don't proceed straight away to cesarean section, it should be used.
The next question, when do you recommend membrane sweeping?
Really only when the patient is at term. So, and 40 weeks in order to avoid an induction for post-term of 41, given that you need to do only 8 in order to avoid 1 induction at 41. I think it's with a 1 in 10 risk of rupturing membranes, you don't want to do this early.
It seems that we're having a little difficulty for some people downloading the handouts. And so I think what we'll do is usually there's a recording that goes out after the session. So we'll attach the handouts to that email when it comes out. So we're sorry about that.
One further question. Do you have any suggestions for pain control in latent phase?
Yeah, and I think that's sometimes quite a difficult problem. I know that where patients are having so much pain, they're exhausted, and they keep coming back to the hospital and pleading, please don't send me home. I think one is be informed in advance that if patients are educated during the pregnancy and antenatal classes, etc., that latent phase is painful, but we try to keep you at home for as long as possible. That then there's sometimes more buy-in if you do that. Supportive person with them from the very beginning. we really encourage mobilization, and we're big on warm water at our hospital. We find the jacuzzi bath makes a big difference for helping with pain control. But I'll be honest, sometimes I have given patients narcotics in the latent phase. I always warn them that, hey, you're going into labor, and if we give you narcotics, we'll probably push you out. But when the poor woman is absolutely desperate and she's in so much pain, what else can you do? And, you know, it's awful to see her suffering so much. But there are such things as, and again, I'm sure there's probably people on this webinar who have more experience than myself, such as sterile water injection, TENS, focus meditation, etc. All of those things which are used by more by doulas and midwives, and all of them are excellent for distraction and helping people to cope with the pain.
There's a question that there's Appendix C missing in the QBP handbook. I just want to note that that was likely an older version of the QBP handbook, and the most recent version is available on the Ministry of Health and Long-Term Care website, as well as also on the PCNCH website. So you may want to ensure you've downloaded the most recent version of that.
There's a follow-up question in regards to the statistics that you quoted on the membrane sweeping and membranes. We want to know, where does that come from, the 1 in 10?
1 in 10. I'd have to look up. I was actually reading the same article that showed, it may be Cochrane. It may actually be from Cochrane, because Cochrane recommends it. So, yeah.
Okay. There was a mention on the VTE prophylaxis, but missed the context and relevance.
Well, I think what we were talking about really there was best practice. In terms of the QBP, we're looking at best practice for the care of these low-risk women in labor, but we didn't stop it there. We realized that some will have longer protracted labors, some may end up with cesarean sections, some may end up with longer hospital stays, and with all these patients we must continue to be best practice, and therefore to remember always VTE prophylaxis with any of those patients.
Okay. What role do you think prenatal education classes could play in assisting with this implementation?
I think quite significant role. Again, prenatal education classes which emphasize the same evidence-informed choices that we have talked about at the expert panel. Prenatal classes from the very beginning about healthy eating, encouraging exercise in pregnant women, identification of malposition, if the fetus is breech, encouraging people to consider doing an ECV, because I know sometimes I have patients with a breech and I say, what about trying an ECV? And they say, oh, no. So that if you talk about the reality of those things happening from early on, people are more prepared, I think, to consider such things as an external cephalic version. Similarly, education about the fact that labor takes a long time, and especially latent phase of labor takes a long time, and that the safest place in latent phase is at home. Place you should not be is in hospital. And if that is emphasized by the prenatal educators, by the doulas, by the support person, and by the primary care provider, and then when they come to the hospital, by the nurses in the labor and delivery, that will have far more impact than if it's just suddenly something that they hear when they're already in pain and they're told, no, go home, you're not in labor. I think also encouraging one-on-one support in labor and encouraging people to think about that. You know, people often get a lot of gifts and do things like spend $150 on a 3D ultrasound for a pregnancy and things like that. And instead, you know, you could say to family, how about you fund me having a doula in labor? Because it's not covered by OHIP, but that way, you know, there's evidence-informed information that doula may help to decrease her chance of a cesarean section.
So there was a question about one of the graphs that we showed, and I just want to...
Can we go back to it? Which one is it?
I think she just wanted to know about what the graph was divided by LINs or C-sections or regions of just low-risk categories.
Oh, so that's the one with the different levels of hospitals. So that's slide 15.
So it's the average rate of cesarean section in QBP target population. So it's the population the QBP expert panel.
We can look at it
again.
We're just going to put that up on the screen.
And it's by hospital and level of care and by LIN for 2012 to 2014.
This one.
Yes,
slide 16. So this is looking at the target population. This is the population the expert panel concentrated on. This is the population that is the aim of the QBP. So again, to emphasize, Robson criteria, Robson category 1, low-risk women, greater than 37 weeks gestation, singleton fetus, cephalic presentation in spontaneous labor. Now, this slide is looking at the whole of Ontario, broken down into LINs, and the bars represent the different levels of hospital. The yellow is the level 3, the green is the level 2, and the blue is the level 1. And if you go across from the left to the right, it's just the separate LINs. So in Erie St. Clair, there's not a level 3 hospital, so it's just level 2 and level 1. Southwest has, and the gray is the total. Southwest has level 1, 2, and 3, and so on. And that is one of the reasons for being pushing for this QBP is the variation. And again, this is just in low-risk women, and this is the variation in cesarean section rates, just based on postal code. And in terms of best practice, one would like to see that far more even.
Okay, so I think this will be one of our last questions. So someone asked, I understand the data only includes cephalic presentation. However, there are recommendations for delivering breech presentation. That kind of brings back to all the best practices that you wanted to mention in the QBP.
So in terms of, for this QBP, and I think that's important because I think at first you think, oh, you know, what's going to happen and all these different patients. For that reason, the expert panel said, let's make this as simple as possible. Let us focus only on that Robson criteria 1, and patients with an abnormal presentation, including a breech presentation, are not Robson criteria category 1. I can't remember what they are, maybe category 7. Breech vaginal delivery does not fit into this. But if the woman is breech and it's detected antenatally, and she can be externally cephalic birthed, and she then goes in as Robson category 1.
Great. So I think that wraps us up for the webinar today. And I just want to thank everybody for contributing some of your questions and some of the comments. Sorry if we couldn't get into every question, but please feel free to email us at info@pcmch.on.ca. We do have the webinar slides, the handout, and the education package all on the handout section on the webinar. But you can also get these resources on the PCMCH website, as well as the QBP handbook on the Ministry of Health website. And your feedback is important to us. We will be doing a post-event evaluation form, so we do want you guys to fill that out. And thanks again.